Morning, everybody. Uh, we just get started in about 2-3 minutes. Just give everybody a chance to log in. Okay. Well, oops. Wait for Altobelli to get back and we'll start. There you are. Well, good morning. We'll get started. There'll be lots of people coming in later, but out of respect for all of you being here on time, we will start timely. Hold on one second. So good morning. Welcome to our Frontiers in Addiction lecture series. I'm Dr. Mo Gelbart, the Executive Director of the Thelma McMillen Recovery Center and the Director of Behavioral Health at Torrance Memorial Medical Center. And thanks for joining us this morning. As I said, we've been doing this lecture series for almost 30 years. We continue to provide 15 to 20 free CEUs per year. We have great partners. Thank you to both Kathleen and Discovery and Cheryl Camby and Meadows. And again, they all work incredibly hard to provide you with the best speakers really in the country. You've seen this year already, and you'll see next year. As I said, our 2023 program has been great, and it continues with a great speaker today who I'm going to introduce in a few minutes. We have another great year planned for 2024, and you'll be receiving the flyer with all the speakers and the dates. But we have people like Claudia Black coming and Peter Levine and many other great speakers. So we've got a fantastic 2024 coming up. We'll continue to be virtual because it's working pretty well. We'd love to see you all, and maybe one day we'll do a hybrid model. But in the meantime, we get a lot more people and our speakers don't have to travel across the country half the time. The next presentation, put in your calendars, is January 16th, 2024. Jeff J, Leveraging the Power of Family to Achieve Durable Recovery. You'll be getting registration emails shortly. Please know, we don't have a December program schedule. So we're dark in December. Give you a chance to enjoy all your holidays. So to start our program, I'll tell you a little bit about Thelma McMillen. Kathleen will talk about Discovery, Behavioral Health, and Cheryl will talk about the Meadows, and then we'll introduce our speaker. During this talk, please put any questions you have in the Q&A box, not the chat box, please. There's a Q&A box at the bottom, and we'll address them at the end. And if you signed up for CEUs, you'll get an email when this is over and fill out a couple of questions, and you'll get your certificate. So the Thelma McMillen Center, we've been serving the South Bay for 32 years. I've been the director from the beginning. We're an intensive outpatient program, and we're part of Torrance Memorial and Cedars-Sinai, two of the top hospitals in LA. We have access to those resources, access to the McMillen Family Foundation, and we're a non-for-profit hospital. So we aim to do what's best for the clients when they come, and not all clients are appropriate for IOP, and we make sure that they get the help they need elsewhere. We have a great staff. The average length of stay in our staff the average length of employment with us is 17 years, which is pretty darn good. They're getting a little gray, long in the tooth, I guess. So we got to worry about that part instead, including me. Our adult program is 9 months. Our teen program is 6 months. And after graduation, clients can continue to participate. We all know that the longer one's connected to support, the better the outcome. We have people in our adult program who come for 20 years once a week, and there's no charge to them or anything. We have a sophisticated hybrid program since COVID, and it's more than just a Zoom meeting, so we can see people who don't live in our community. If they are sick, they can still Zoom in. If they are away on vacation, they can still continue with that program. So that's going really well. We work very closely with professionals in the community, psychiatrists, therapists, physicians, and as I said, we do a comprehensive assessment, and sometimes what the person needs is not us, and we make sure they get the right care. We are covered by almost all insurances except Medi-Cal, and we hope you'll consider us for your patients with alcohol or drug issues, and just know that we'll work hand in hand with you. So with that, I'll turn it over to Kathleen.
Thank you, Dr. Gelbart. And as you said, yes, I'm Kathleen Ballou, Clinical Outreach Manager with Discovery Behavioral Health, where the mission and belief is that everyone deserves a happy, rewarding life. With more than 160 treatment centers nationwide, Discovery has been providing treatment for 25 years and has made evidence-based, outcome-driven healthcare accessible and affordable since its inception. Discovery Behavioral Health now offers a full continuum of care, providing detoxification, residential treatment centers, partial hospitalization, intensive outpatient, psychiatric and addiction medicine, TMS, and virtual telehealth services for children and teens age 11 to 17 and adults who are struggling with mental health, substance use, and eating disorders. In Southern California, we have 2 substance use disorder treatment programs, Casa Palmera and Cliffside Malibu. New to our program, fairly new, not super new, but fairly new. The Mental Health Division teen program out in Long Beach is now a full DBT program that provides comprehensive DBT for patients with much more complex behavioral health needs. Also, as we know, access to behavioral health care can be challenging, and that is why Discovery has continued to be an in-network contracted provider with approximately 100 insurance and other managed care organizations, including Kaiser, TRICARE, and the Inland Empire IEHP, also TriWest. Finally, Discovery understands that when sometimes it's hard to find available treatment, practitioners are very busy right now. Sometimes it's hard to get in. And as such, I'm always proud to share that we are able to provide free online support groups in both our mental health and eating disorder divisions at www.supportinrecovery.com. I'll put that in the chat, so you'll have that as well. Please feel free to reach out to me after the event if you have any questions. And I'm happy to be a resource for you. And now I am happy to pass this on to my very good friend, Cheryl Campe.
Thanks, Kathleen. Good morning, everybody. My name is Cheryl Cambe with Meadows Behavioral Healthcare. Thank you for joining us every month and this morning. The Meadows has specialized in developmental and relational trauma and PTSD treatment for over 45 years. Our proprietary trauma model was developed by PM Melody and is integrated in all of our programs. We treat addiction, dual diagnosis, and primary mental health in inpatient, residential, and in-person intensive outpatient programs. Our inpatient programs are located in Arizona, California, and Texas. Our outpatient centers are located in various locations across the country, with more to open through the end of this year. We also offer virtual intensive outpatient programs separate from our in-person outpatient programs and continue to grow both outpatient services and virtual services across the country. In addition, we have a standalone Rio Retreat Center in Arizona offering over 15 different 5-day therapeutic workshops and private intensives. Our specialty programs include treating problematic sexual behaviors, porn addiction and love addiction, eating disorders, process addictions, compulsive disorders, codependency, and relationship and intimacy issues. The Meadows trauma modalities offer a focus on brain and nervous system regulation through our somatic therapies and our Meadows brain centers offering neurofeedback and biofeedback devices. We have brain centers located on every Meadows campus. Our Arizona inpatient programs and some of our IOP locations are in network with TRICARE and TriWest, proudly serving active duty military service members, families, and vets. Along with PMLD, our Meadows Senior Fellows include, they clinically inform our treatment. It includes Bessel Vanderkolk, Peter Levine, Patrick Carnes, Dick Schwartz, Claudia Black, Resma Menniken, Kevin McCauley, also including Dr. Lawrence Heller and Dr. Bruce Perry. Dr. Bruce Perry is part of our new adolescent center that just opened last month, which is, we are utilizing Dr. Perry's neurosequential model of therapeutics. The Meadows Adolescent Center in Arizona is a 10-bed facility for boys, ages 13 to 17, trauma treatment on a 120-acre property that features horse trails, adventure, and wilderness activities, along with psychodynamic work. We also just recently opened the Spiro Center at the Meadows, part of the main campus. Spiro Center is both a short-term stabilization program for higher acuity, as well as a standalone residential treatment program for individualized, gentler approach to treatment for clients with complex mental health issues and emotional fragility, where a Meadows program is not a great fit. Please visit us at meadowsbh.com. I will also include my contact information in the chat. We are also hiring across the country as we are opening more outpatient centers. I will also include the career chat link in the chat. I want to wish you a happy Thanksgiving and happy holidays, and I will turn it back to Dr. Gelbart to introduce our speaker.
Thank you, both Cheryl and Kathleen. So I'm excited now to introduce our speaker. You're all going to be excited. Dr. Eva Altobelli, MD, is the founder of Home LA, a holistic wellness center integrating somatic therapy, psychotherapy, psychiatry, and psychedelics. Dr. Altobelli started her career working as a filmmaker in New York City while exploring mindfulness, yoga, neuroscience, and expanded states of consciousness. Returning to school, Dr. Altobelli completed a psychiatric residency and fellowship in addiction. She is a diplomat of the American Board of Psychiatry and Neurology. Her career involved working in detox, rehab, and private practice, as well as consulting in psychedelics, addiction, and recovery, teaching and mentoring. She is certified in psychedelic therapy and research from California Institute of Integral Studies and by MAPS, Multidisciplinary Association of Psychedelic Studies, to treat PTSD with MDMA. She has extensive postgraduate trainings ranging from Reiki to psychoanalysis. During her career, Dr. Altobelli has evolved a holistic practice, integrating mind, body, and spirit into the healing process. She specializes in creative ways to help clients find their way to recovery and wholeness. It's my pleasure to introduce Dr. Altobelli.
Hi. It's a little embarrassing to hear yourself dressed like that, but thank you very much. It's a pleasure to be here with all of you. I'm going to share screen right now and jump right in. Let's see. Okay. Hold on one second. I gotta do this. Are you seeing just the?
We see the banner on top, but that's okay.
Okay.
If you can't get rid of it, it's no big deal. But the screen is full.
Okay, good. And it's just great. So here today, we'll be talking about the therapeutic use of ketamine, psilocybin, and MDMA. I cover a lot of topics, so just kind of go with it. And I'm really excited to be here to talk about psychedelic integration, integrating psychedelics into our current mental health framework. As Dr. Gilbert mentioned, I'm an addiction psychiatrist, and I'm also a mother and a daughter and a wife and a friend and a deeply curious person. The curiosity is what led me towards the more creative healing modalities, including non-ordinary states of consciousness. And I've learned from so many teachers over the years that what I'm sharing here is a mixture of science, art, and personal experience. Some of the molecules we're going to talk about today have been around for decades, but now with peer-reviewed academic research, they're entering the mainstream therapeutic discussion. We'll start with a brief history of how we got here. I'll be discussing ketamine, psilocybin, and MDMA, uses, and a bit of neuroscience. Ketamine is currently the only legal medicine for transformational healing. MDMA and psilocybin can be used for research at this time, and they're their laws are actively being written to integrate them into our medical framework. We're not exactly sure when and how that's going to happen, but I think it's coming in the next year or 3. So let's start with chemist, Dr. Albert Hofmann. He was working in a lab in Switzerland in 1938 to synthesize a compound for cardiovascular and respiratory health. And that is when LSD was created. The chemical didn't serve his purpose, so he shelved it. And years later, in 1943, he was re-examining the compound and he accidentally absorbed some through his fingertips, and he had the first synthetic psychedelic trip. And this discovery opened the door to a new thought-provoking paradigm of consciousness. In the United States, LSD was studied in the 1950s and 60s in both low-dose and high-dose models, similar to how we're using MDMA and psilocybin in current research. The low dose is used to loosen up and dissolve defenses. The higher dose supports mystical experiences. Research indicates that individuals having a mystical experience have a higher potential for change. Hallucinogens can shift our perception of reality, allowing one to perceive a feeling of connection and wholeness with a purpose, which may lead to the extinction of self-destructive lifestyle patterns. Internationally, positive research came out of these studies on the benefits of LSD therapy for alcoholism. Even Bill Wilson, the founder of AA, found psychedelic treatment to be therapeutic, but politics of the time didn't allow for it. And in 1965, LSD was reclassified as a Schedule I drug with no medicinal or research benefit for 2 decades, until in the 1990s, psychedelic research was restarted. In 1963 to 74, psychiatrist Stanislav Grof was responsible for over 4,500 LSD-assisted therapeutic interventions. When psychedelics were reclassified and no longer available, he leaned to accessing non-ordinary states of consciousness through other means, developing holotropic breathwork. Here's a kind of a loose, non-comprehensive time frame to highlight some events. After 20 years dormant, the research started in 1990 when Dr. Rick Strassman gave DMT to healthy volunteers. In 1993, Drs. Nichols, Grobe, and Greer opened the Hefner Institute in New Mexico to advance the study of psychedelics in the treatment of mental health. And in 1999, Johns Hopkins University was the first academic institution to open up a psychedelic research program under Dr. Roland Griffith, who recently passed away, and Dr. Bill Richards. In 2011, my mentor, Dr. Charlie Grobe, published research demonstrating psilocybin's efficacy in reducing anxiety in patients with advanced cancer. In 2014, it started coming out in more publications, and we saw Dr. Robin Carhart-Harris and his team at the Imperial College of London documented through neuroimaging psilocybin's ability to enhance neural connectivity. And in 2019, ketamine was reclassified as a medication to treat major depressive disorder. Internationally, there are over 1,000 clinical trials producing promising results that show the benefits of using psychedelic medicines for the treatment of addiction and mental health disorders. Western psychopharmacology has made its living reducing symptomatology, but we're not great at preventative care, and we're not great at getting to the root cause. Transformative healing with psychedelics as a treatment approach is quite different. The goal is to empower healing from within. The clinical trials demonstrated significant results. After treatment, 67% of people no longer tested positive for symptoms of PTSD. Psilocybin is now decriminalized in certain areas in the United States, and the path to approval is pending. Research is entering the final stages. Newsom recently said no to the bill to decriminalize it, so I think it might look like it will be decriminalized closer to 25 or 26. The research and potential applications of these compounds is significant. As you can see the list here, it's currently associated with anxiety, associated with cancer diagnoses, PTSD, major depressive disorder, eating disorders, autism, OCD, conflict resolution, personal growth, addiction, childhood developmental trauma. Ralph Metzner is a psychologist and author. He's an elder in the field of psychedelics and transformational change. I saw an article he wrote actually on, there's a 12-step meeting called Psychedelics and Recovery, and there are a couple articles, and I saw this article where Dr. Metzner talks about the angle that we experience life through is about a 45-degree angle. And once we bring psychedelics on board, it opens up to about 180 or even 360. He then also talks about the contracted angle that we experience when we're experiencing rumination, depression, addiction, OCD, any compulsory repetitive behavior patterns. So here we're sort of exploring the contraction versus expansion. With the expansion comes more awareness and opportunities. He tells a little story about a skit Richard Pryor did where he was having a conversation with his crack pipe, and his crack pipe said to him, "Richard, you don't need anybody. You don't need your wife. You don't need your house. You don't need food. You don't need anything. It's just you and me, baby." So in that, he's really highlighting the angle at which you get caught in. And psychedelics bring the potential for treating these narrow-angled maladies with angle-widening therapies. All right, now let's jump into treatment. Whilst this might not be the right path for all clients, these treatment modalities do offer a rich potential for healing and change. As I mentioned before, Western psychiatric medicines work to dampen symptoms and avoid pain without addressing the root cause. I've spent over a decade prescribing medications so that clients can reduce their capacity to feel. With psychedelics, we learn to go towards this discomfort and ask what it wants to teach us. As a psychedelic therapist, our agendas and goals shift to let the medicine and the client's inner healer find the way. We support our clients during these sessions. Like psychotherapist Michael Ballant states, we remain ordinary and unobtrusive. The hierarchy of therapist and patient is shifted in psychedelic therapy sessions. The participant is the expert, not the provider, which has been quite a relief for me. The sessions can also offer a different level of transparency and sometimes appropriate and acceptable contact, like hand-holding, that's discussed and agreed upon prior. Clients often want to know if we'd had access to the medicines, and I've found that sharing some of my experiences creates a stronger connection with clients. Some of the benefits of psychedelic medicine are allowing for a deeper access to our core selves, inviting the inner witness to come online. By this, I mean it can increase our awareness and the space between our experiences and our reactions. Exploration of the survival mechanisms that inform our perception and responses. Exploration of transgenerational and transpersonal traumas, and integration of mind, body, and spirit into the healing process. I find this model to be helpful to delineate some of our architecture a bit. I believe that we come into the world as innocent beings and develop patterns of behavior in response to the world around us. Wilhelm Reich, a psychiatrist who trained with Freud, was the first to talk about somatic defenses. He referred to them as body armor or character armor, and the armor speaks to the styles in which we've learned to respond to the world as we experience it. We arm ourselves not only with defenses, but also with physical holding. These medicines help us access ways of healing in nonverbal, nonlinear paths that can help us get to the core of our unconscious defenses. The core here is our true essence beneath the defenses and the survival patterning. Our primary impulse is the unconscious neurobiologic response, like our sympathetic nervous system arousal. The molecular armor here is the unconscious way we structure our physical body to feel safe. And the secondary impulse is our knee-jerk response. It may seem unconscious, but if we slow down and think about it, we see it's not. Here's a nice quote by Dr. Wright. Once we are open to the flow of energy within our body, we are open to the flow of energy within the universe. I'd like to highlight the importance of intention, set, and setting with psychedelic therapies. The word set refers to the mindset of the individual. And the setting is every piece of sensory information that's experienced. The temperature, sound, smell, feel, visual imagery. Psychedelics have been used in ritual and community. As we medicalize them, we're chemically stripping away an individual's defenses, allowing them to see and feel what's buried. So we need to create an atmosphere where the individual can feel safe enough to do so without shame or contraction. A feeling of safety is paramount in creating a therapeutic space. We honor the relationship we're co-creating, discussing intentions and discussing letting them go. Practice having a dry run of what it feels like. Discuss consent to touch, example, hand holding. We discuss what this level of vulnerability might feel like and how unsettling it can be, and ask if there are any parts that have apprehension, and we explore them together before moving forward. The setting is dim lights. I light candles and burn Palo Santo or sage or spray lavender. We use curated soundtracks with attention to the surroundings, blankets, some like weighted blankets, soft edges, limited religious icons. We can invite clients to bring in a totem or a photo. This is usually more common in the MDMA and psilocybin, the longer journey experiences. Lack of safety and trauma reduce our capacity for novel thought. So it's going to be very difficult to imagine developing a different pattern of reactivity if you're not feeling safe. These medicines can offer cognitive flexibility, but we need to feel comfortable in order to expand in that way. So let's touch on the stages of treatment. Assessment is the initial meeting to medically and psychiatrically clear a client for treatment. Preparation. It's an informative experience designed to answer any questions about the process, address concerns, and educate the client for best results and set expectations. Here we spend time considering an individual's motivation and intent for treatment. We also spend time discussing different potential experiences. Medicine is administered in a medically supervised environment, monitoring for blood pressure and pulse. We have clonidine and Zofran on hand to address elevated blood pressure and nausea. The physical space is structured with intention for clients to drop in deeply and comfortably. Ketamine intoxication is usually about 1 hour. MDMA and psilocybin are closer to 6 or 7 hours. Integration is the therapeutic process that takes place after the medicine session. It involves the processing of insights and information accessed during the altered state and the days that follow. Here, we can develop new perspectives and increased psychological flexibility. It's an ongoing process, and it can take years. It's otherwise known as therapy, psychotherapy, really. It's not limited to verbal processing. It can include somatic work, art, nature, energy work, acupuncture. There is a fertile period after the session that's a relevant opportunity to begin new healthy habits, such as meditation, mindfulness, gratitude, and of course, new possibilities. Okay, so here's a couple slides on neurochemistry, and just kind of let it wash over you. It can get a little detailed. I'll start with a few terms so we're all on the same page. The default mode network system. You may have heard of this. It's interconnected neurons that are active when we're not doing. They are responsible for our internal driven thoughts like rumination or self-criticism. Also, our sense of self or sense of ego. The default mode network is more active in states of depression and lower in selfless states. Psychedelics decrease activity in the default mode network, so we are less self-driven. Psychedelics allow for increased connectivity throughout the brain, allowing for new thought patterns and therefore new behavioral opportunities. Imagine a ski slope with paths dug into the snow, and then psychedelics are like a fresh coat of snow, so there's no trails and it's easier to explore new terrain. During childhood, our brains have a diffuse set of connectivity. As we age, we develop neural pathways that help define our personal reality. We can get stuck in these patterns, and psychedelics create an opportunity to connect new and different pathways. Synaptogenesis means the development of new neuronal connections. Neuroplasticity refers to the resilient capacity for neurons to branch out and make new connections. Oxytocin is a hormone naturally produced during orgasm and breastfeeding. It lends itself to feelings of love, connection, and empathy. And the amygdala is a walnut-sized area of our brain responsible for elevated emotional charge, like anger, fear, and rage. These will all come up in the future slides. So let's talk a little bit about mechanism of action and the areas in the brain most affected by ketamine and psychedelics. Here you see, I'm going to introduce two cells. In blue, you'll see the pyramidal cells, and the little cells are the chandelier cells in yellow. The pyramidal cells are excitatory neurons densely populated in the prefrontal cortex. They're responsible for attention, perception, awareness, essentially consciousness. And the chandelier cells are inhibitory interneurons. They reduce the activation of the pyramidal cells. Think of them as the brake. So ketamine is a glutamate modulator, and it acts on the chandelier cells. Effectively, they dial back the inhibition of pyramidal cells. And when the pyramidal cells are released from their inhibitory control, they fire more robustly and diffusely. So ketamine allows for a more robust, diffuse connection. Traditional psychedelics work directly through 5-HT2A receptors on the pyramidal cells. And remember, these cells are already excitatory neurons, so they don't need much to fire. So when you bring psychedelics on board, they overwhelm the inhibitory compensatory capacity of the chandelier cells, and it's a more aggressive release of inhibitory tone. If you think of it like a garden hose, with ketamine, the diameter of the hose is larger. The velocity of the flow is the same, but more comes out because the diameter is larger. With traditional psychedelics, and by that I mean LSD, psilocybin, DMT, mescaline, traditional psychedelics, the velocity of the flow is ramped up, which is why ketamine feels more gentle and traditional psychedelics are a faster ride because the diameter is larger and the flow is way more extreme. Okay, here, this is a simpler one. We see dendrites. Dendrites in the top, you see, they grow. First, dendrites grow out of the cell body. Their mission in life is to allow for communication. In the top image, you see a dendrite at baseline. And on the bottom, you see one with the addition of ketamine. Ketamine increases the strength of the dendrites and the amount and strength of branches. Think of it like a spindly tree or a healthy tree with longer branches that can reach out and make more connections, leading to increased cognitive and emotional flexibility. Okay, this is the last neurochemistry slide. New research discussing psychedelics and their effects talk about the critical learning window. When we're young, we have an increased capacity to learn. Have you heard about, you teach a kid a new language young because they're more moldable. It's easier to learn a new language when you're a child. So researchers are calling this the critical learning window, and ketamine has the capacity to reopen that critical learning window. You can see here in the diagram, all of the connections that are made. This is specific to psilocybin, but this image is also consistent for other psychedelics and ketamine. So a reopening of this critical learning window allows for new patterns of thought and behavior to be learned more rapidly. Researchers are looking into this not only for mental health, but also for post-stroke, so that clients can be given ketamine before going to occupational therapy to relearn a lost skill, such as speech or use of a limb. It's important in terms of how we position ketamine. So it's not as much about the medicine alone, but it's about what we do with the window of opportunity after ketamine or other psychedelic administration. Okay, so now let's jump right into ketamine. It is a dissociative anesthetic originally used for pain management and surgery. It was reclassified as a medicine to treat major depressive disorder in 2019. Ketamine is versatile. It can be administered intravenously, intranasally, orally, or intramuscularly, and different administrations highlight different benefits. The early research came out and demonstrated that clients suffering with treatment-resistant depression and suicidality, ketamine has been very effective when administered in a series of sessions close together. At our clinic, we use oral, intranasal, and intramuscular for ketamine-assisted psychotherapy. The acronym is called CAP. So during this, I may be using the term CAP, and when I say that, I mean ketamine-assisted psychotherapy. The oral administration comes on slower and is a more gentle experience. Using this route of administration at a low dose, clients are more available for talk therapy. We refer to this dose as psycholytic talk therapy. Low dose intranasal comes on and wears off faster and is also quite helpful for psycholytic therapy. The intramuscular injection can offer the same benefit as oral with a dose-dependent short-term dissociative experience. With a higher dose, whether it's oral or intramuscular, one has the potential for a psychedelic experience. The onset of action. So here you see time in horizontal and the intensity in the vertical axis. The pink is the intramuscular. So you come in and you get a shot of ketamine. You'll start feeling it in about 2 minutes. It peaks at about minute 9 or 10, and the whole remaining 50 minutes, it slowly tails off. In blue, you can see intravenous, which is largely controlled by the anesthesiologist or tech. It's dialed up, maintains that constant dose, and then dialed back down. But it can be adjusted by who's ever working the dials. In green, you see oral. It's a slower increase. It takes about 20 minutes on. You're at peak for about 20 minutes, and then a slow, steady tail too. There's another process I use called pulse, because let's say a client's therapeutic dose of ketamine is 100. If I inject them with 100 milligrams, they can potentially lose the gains that they experienced when they come back. They can forget some of the experience if they're too altered. So instead of a single 100 milligram shot, I find if you look at that pink arrow, you'll see you'll go up with 50 milligrams and then they start to come down. And then 15 minutes into the experience, I give them another injection of 50 milligrams and they slowly come down for the rest of the time. So it sort of mimics the IM, maintaining a higher dose for the bulk of the middle of the experience. A leading benefit of CAP is that it can help dissolve defenses consciously and unconsciously, leading to greater insight. Ketamine-assisted psychotherapy can also allow us to re-experience and remember parts of our lives without the emotional charge of the memory. Patients experience emotional disconnection, creating opportunities to reintegrate stories without the associated pain. Ketamine-assisted psychotherapy facilitates healing by accelerating one's access to insights, augmenting the psychotherapeutic process. For us at Home LA, a typical CAP session lasts for about 3 hours. Prior to the session, a client fasts for 2 hours. Upon arrival, we usually do a relaxing grounding. We talk for a little bit, and then we do a relaxing grounding exercise, such as a meditation, to drop into the field and be in the room together in a non-verbal state. Clients are encouraged to lie down on the sofa, pillow, clean sheets and blanket, sometimes the weighted blanket, wear eye shades and headphones with a curated playlist. We administer the ketamine, and then we sit and either meditate or read by their side for the time that they are internal, usually about 45 minutes. When they rouse, we have a therapeutic hour together. I ask clients to speak kind of as if they're recounting a dream, not full sentences, any words, thoughts, sort of anything stream of consciousness. And I just write everything down, and we use those notes for integration in future meetings. They do tend to be valuable trailheads for the future. Here's an example of a benefit of dosing flexibility. I have a couple case examples here. So we'll call him Ted. He's a 60-year-old man. We've been working together for about 8 months, and his working diagnosis is addiction and developmental trauma. Ted had previously experienced benefits of high-dose ketamine. This time he arrived with the same intention, but was presenting with really elevated agitation. He came in saying how angry he was, and because of our history together, I knew anger was an important part to explore. So we pivoted from the psychedelic to psycholytic, which is a good opportunity for us to utilize the low dose and remain talking together rather than him dropping into a psychedelic nonverbal state. So during the session, while he held the ketamine in his mouth, you have to hold it in your mouth for about 10 minutes. It's absorbed through the oral mucosa. So the 10 or 15 minutes that he held it in his mouth, I have like a deck of oracle cards. I had him pick one, and he picked Illuminate Your Shadow. So I asked him if he wanted to work with his angry part. He nodded. And after he spit, you could spit or swallow. Most people spit so they don't get nauseous. Some people get nauseous, not everybody. Okay, so he spits, and then I asked him about his angry part. I asked him where he felt his angry part. He said he feels it all over his body, his upper body, his arms, his neck, his back, his hamstrings. He said it's as if I'm coded for violence. I asked how he felt about the angry part and what is its job. And he said his job was to protect me from my father. He acknowledged that his angry part is trying so hard, and it felt ashamed and hurt and tired that as hard as it tried to protect me, it couldn't. I asked, how old does the angry part think you are? And he answered, age 3 and age 7 and age 16 and 27. So he came up with specific autobiographical periods of his life that were specific and succinct, clear memories for us to process together. He described this as the first time he realized how exhausted and hardworking his angry part is. He'd always known its goal was to protect him, but this was the first time he acknowledged the complexities of how it felt with compassion and a more profound understanding. Some clients experience ketamine as floating. One can see colors in their mind's eye, or events from their life pass them by without the emotional charge of the memory. I kind of liken that to Dorothy from The Wizard of Oz. Clients also describe an emergence of an inner witness. I've seen the observer parts organically come online during integration, people feel a sense of emotional spaciousness. One client said, I experienced the parts of me that really wanted to run away, but I was separate from it. I was witnessing that part. They describe separation, and this sort of organic unblending that occurs speaks to the language of internal family systems, which is commonly used in psychedelic therapy sessions. Clients describe a shift in perspective. One described seeing my experience close up in detail, and then from a different angle, and then zoomed way out, and then within the context of everything. Some describe a shift from concrete thinking to more abstract processing, where more therapies exist. Here's another example that seemed more like the transpersonal healing modality. A client's awareness was coming back after her ketamine experience, and she described meeting her father, who died a few years ago, seeing him with his mother, who was also deceased, and seeing him for the first time whole and complete and healthier than she'd ever seen him in her whole life. He wanted to give her the sense of wholeness and healing and support so that she could have it and also give it to her son. She said she actually felt it in her back, in her spine. The whole back of her body had a sense of support. She said she felt really tethered to this connection of her ancestry in a grounded way that she had not experienced before. And in meeting with her afterwards, she maintained this sense of connection. I've also sat with clients that have been blocked. Some defenses can even block medicine. Here is a client who stated that nothing happens, and he was given a considerable amount. So our discussion revolved what meaning that had for him. The client was a male. He said, I felt like it wasn't enough and I wanted more. The whole time it felt like it wasn't enough and I wanted more. We explored what wanting more meant to him. He described even when he was using drugs early in his life, he was never high enough and he always wanted more. He describes in childhood a trauma. He held an intense family secret alone and for decades shut part of himself down and he stayed hidden. This led him to having a small life. He said, I could have had friends. I could have had a career, a life. I always wanted more. I compared myself to my dad and his big, wonderful life, and I feel like I just hid. So client describes wanting more in multiple areas of his life. So you could see the initial disappointment was an opportunity for us to dig deeper in this as well as future non-ketamine sessions. Okay, now let's move from ketamine to MDMA or ecstasy or Molly. First introduced therapeutically, it became a club drug, which led the DEA to also reschedule it as a drug with no research or medicinal benefit. 3,4-methylene deoxymethamphetamine. MDMA is an amphetamine and a psychedelic. It's also referred to as an entheogen, which is a compound that alters consciousness for the purpose of spiritual development. MDMA downregulates blood flow to the amygdala. That's that little walnut-sized nugget we talked about before, which is the house of anger, rage, and fear. This is useful during therapeutic experiences as clients can revisit difficult memories without the charge, allowing for reprocessing and a corrective experience. MDMA also increases oxytocin, which enhances feelings of love, connection, and compassion for self and others. MDMA was used primarily for couples therapy and empathetic communication in the 60s and 70s. It wasn't reclassified until 1986, 85, I think. The current research has all been with individuals, but I'm sure we can all see a significant potential for conflict resolution utilizing MDMA in small groups, families, companies, even governments. MDMA is targeted to be rescheduled by 2024. I think it's going to be the last quarter of next year. MAPS, the Multidisciplinary Association for Psychedelic Science, is training thousands of therapists right now to treat clients with PTSD using MDMA facilitated therapy. MDMA and psilocybin protocol are long and intensive. Here you can see Annie and Michael Mithofer and the MAPS team. They co-created and teach the modality. Cumulatively, therapy lasts for about 42 hours, and we see a lot of time is dedicated to therapy and relational healing, in addition to the medicines. MDMA has undergone a lot of research with veterans, which have shown profound healing. And here you can see the research protocol. First, there's the screening, and then the smaller blue lines, there's 3 preparatory sessions. And then in the lighter blue-gray, there's 1 8-hour medicine session, followed by 3 more integration sessions. Integration, again, just a fancy word for ongoing therapeutic relationship. The research protocols have shown the importance of the preparation as well as integration, and how the time an individual spent alters as a result of the medicine is really just a small fraction of the treatment. Compass Pathways, actually a for-profit organization in psychedelic research, did some research without much clinical support because they thought they could save money, but their outcomes were poor, which, as you know, it benefited us psychotherapists because it indicated that it's really valuable to have all of the therapy on board to make change. Oops. Okay, so as I mentioned, MDMA research is right now limited to individuals, but historically, it was used, a pioneer, Leo Zeff, was using MDMA with couples and also in small groups. So this is a picture of, and I'll give you a little description of what a typical MDMA group therapy session looks like. People come into a shared space, prepared with intimate lighting, comfortable places to relax, lie down or sit. Initially, individuals sit in a circle, connect, discuss their intentions. Then everybody takes MDMA and lies down and has their own individual journey, but in a group setting, allowing for the opportunity of connection and growth through relational healing. After a couple hours, when the MDMA subsides, there's the first round of integration where they go around in a circle and everybody talks a bit about what their experience was like, but everybody is still a bit altered at that time. And there's a lot of healing that can happen in these spaces as you're quite porous. The healing isn't limited to the personal field. It can be intergenerational or transpersonal. These phenomena are more available in that space as we've loosened some of the boundaries and layers of protection that we're accustomed to holding, which is also a reason to be really careful about who you work with. The group generally has some food, has a couple of hours sleep, and then comes back together. You don't leave, you kind of stay together, and then you process group integration when you're not altered and explore really much deeper how to integrate new ideas into your life and to create sustained change. Okay, now we're going to shift to psilocybin mushrooms, and then we'll talk a bit about both micro and macro dosing. Mushrooms are interesting. They're not a plant or an animal. They actually have a kingdom all their own, fungi. Many have theorized that mushrooms have a consciousness. I believe we could learn from them. Their root system is referred to as a mycelial network, as you can see in the bottom picture. It's all connected underground. And through the system, they share energy, they share nutrients, and information are all directed where it's needed to sustain healthy growth of the ecosystem. Looking at medicinal anthropology, we can trace sacred use of psychedelic mushrooms in ceremonial Aztec and Mayan cultures before 500 BC, as well as in Siberia and many other cultures a long time ago. That's a whole other talk we could do on history. So psilocybin is a prodrug converted in the body to the active form psilocin, which has mind-altering effects on serotonin receptors. Here you can see the chemical structure, and you can see that psilocin and serotonin are very similar, just one extra NH2 group in the upper right. Psilocybin usually takes about 20 to 40 minutes to kick in, lasts between 2 and 6 hours depending on the dose. With the higher doses, individuals usually experience a peak at about 2.5 hours in. Here's some approximate dosing and effects. You could see at the top, 5 grams of mushrooms is a full 6, sometimes 8 6-hour psychedelic trip. 3 grams is also a full psychedelic trip, just a little less intense and a little shorter in duration. 1 to 2 grams of mushrooms, really 1 is kind of a good dose to take a hike in nature with friends. You can laugh a little bit more, colors are brighter. 500 milligrams or a half a gram, individuals may experience increased sensory perceptions, and the lower dosing, 100 to 300 milligrams is the microdose range, and that is typically undetectable. Microdosing is the use of sub-threshold doses of LSD or psilocybin. This conversation is about psilocybin though. Generally between 150 and 250 milligrams. So 250 is a quarter of a gram from we saw that from this slide. There hasn't been any research. It's really difficult to do research, but there's been a lot of naturalistic studies, like thousands and thousands of naturalistic reports indicating that microdosing has been helpful for depression, ADHD, athletic performance, creativity. The standard protocols are 4 days on and 3 days off, or every other day for about 3 months, and then you take a pause. There is the reason it's a couple of days on and off is because after 2 or 3 days, the effect lasts a couple of days and the effect wears off after a couple of days. So it's not ideal to do daily dosing. There is something called the triple stack that mycologist Paul Stamets helped develop, which is a mixture of psilocybin, lion's mane, which is another healthy legal mushroom, helpful with digestive age and cognitive benefits. But if you mix psilocybin, lion's mane, and niacin, it makes the psilocybin more effective. Niacin is a B vitamin, I think, and it vasodilates, helping the psilocybin and lion's mane get into the circulatory system. The microdosing protocol should remain sub-threshold so you don't feel it, like the same way you don't feel Prozac. Some participants do feel a lift of mood, lift of energy, increased activity, creativity, and over time, long-term cognitive flexibility. Most of the clinical trials with psilocybin that they were mostly for anxiety in later stage cancer diagnoses and used about 3 grams. So every trip and every human is different. So there's no single description, but loosely, it starts with a physical sensation where you feel your body a little bit more. Some people get a little nauseous because there's a ton of serotonin receptors in the guts. There's an opening of the senses, colors seem brighter. With the eyes open, some people experience trails following moving objects. And with your eyes closed or covered, people often experience visual imagery or sacred geometry. Some experience hallucinations with eyes open or closed. Under the influence, we have access to every memory and experience we've ever had, as well as the collective unconscious. For those open to it, have access to transpersonal experiences, which can be difficult and healing. Bessel van der Kolk spoke about his trip, stating he experienced the grief and sadness of everyone he ever sat with, stating it was heartbreaking and heart-wrenching and powerful and healing all at the same time. This is a slide talking about somatic release, which can occur during psychedelic medicine or holotropic breathwork session. I've witnessed somatic release to be involuntary shaking or vibrating of certain limbs or body parts. It's understood that a somatic release is the medicine's way of allowing the body to process trauma that's been trapped in the body. Somatic work is really important for integration. Integration is the most important component of psychedelic medicine therapy. It's ongoing and can be described as the process of exploring ways to make meaning of what was discovered during the medicine sessions. I'm having a lapse in cognition. I'm looking at my book, almost on my bookshelf. Who's the author who wrote about the psychotherapist after the Holocaust? He wrote this beautiful book. Everybody knows his name. I'm so sorry, I'm forgetting it right now. He speaks that trauma, without the benefit of making meaning of your trauma, is healing. I'll think of his name probably by the end of this talk.
Viktor Frankl.
Viktor Frankl, thank you. Okay, so integration. This can be facilitated with a therapist exploring a variety of ways to make sense of what happened and create a greater sense of wellness in a sustained way into your body, spirit, soul, lifestyle, relationship, marriage, parenting, relationship to money, relationship to the earth. This is where we get to make a paradigm shift from healing ourselves as individuals to the awareness of healing within a community and a system in a society. So it speaks to potential. I've worked with ketamine for a number of years, which is a shorter, more gentle version than traditional psychedelics. MDMA and psilocybin have the potential to launch people way farther out and for longer periods of time. So I've learned some navigation tools from a mentor of mine, Dr. Bill Richards, a psychologist, theologist, researcher. He described the ineffability of the psychedelic experience. That word means there aren't words for it. And so to conclude, I would like to share his 10 principles of navigating the internal world during a psychedelic experience. He describes making a decision to trust. So this is us dropping into our psychedelic experience and deciding to trust, to explore courageously, to relinquish control, receive, and learn. He describes a metaphor of a path of a boomerang. You will come back. Some people get concerned that they're losing their minds and they'll never come back. You will come back. And the mantra is in and through. Okay, number 2 is grounding. Being aware of a feeling of safety in the setting and the development of the relationship with the people that will accompany you on your journey. Verbalize mistrust if it should occur, and normalize physical contact. Reaching out anytime. It doesn't need to be a crisis. And we can be sensitive to shifts in comfort levels regarding touch during the course of an 8-hour journey. Number 3 is effective openness. Open to the entire spectrum of thoughts and feelings that are available and accepted. Tears of joy, sorrow, laughter, anger, sensuality, emptiness, despair, cynicism, anxiety. Number 4 is courageous acceptance. Open to the opportunities as they arrive. If it enters the field of awareness, we meet it. He taught that the mind knows what you're ready to tolerate. And if you're ready to deal with it and tolerate it and face it, it's let in. Otherwise, it stays protected. Number 5, intention. The power of the intention and the willingness to release the intention during the experience and welcome whatever arises. Exploring imagery, staircases, doorways, tunnels, paths, changing from age, regression or progression, becoming an animal or a bird, being open towards things that appear scary. If something scary comes your way, face it. It takes more energy to try to avoid it. Working with psychosomatic symptoms. If it presents itself, we explore it. Nausea, dive into the stomach. Headaches, imagine a tunnel from the forehead to the sensation. Exaggerate instead of trying to control or suppress. Move into and through difficult experiences or nothingness. Number 8, deal with intellectualization. Pre-plan for it. Bribe the intellect to go out and take a walk or play for a while, and then come back online and think about these new experiences that have occurred. 9 is welcome spontaneous movements as long as it's safe. And lastly, be kind to the ego. In summary, psychedelics affect the lens, allowing us to see from new and different perspectives. I see psychedelics as an invitation to contemplate how we think about ourselves and the world around us. And looking through a compassionate lens, I feel optimistic that we can be on a healthier path towards wholeness together. Thank you very much for your time, and I'm available. Now we can sort of drop into discussion because I know there's a lot of stuff. Oh, and I'm also available. Home LA is the organization, and Here's the website and the phone number. And if this piqued your interest and you would be further interested in psychedelic conversations, my office is located in Santa Monica, and we offer a free gathering monthly called Psychedelic Conversations at Home to discuss the integration of psychedelics into our current mental health framework. I also offer clinician experientials, which is an opportunity for people in the healing arts to have their own ketamine learning and healing experience in a small group, kind of like I showed you in the MDMA. It's similar, but we do it with a little bit more training orientation. We have a psychedelic training program that's about 4 months long, starting in February, as well as really cool workshops, one for IFS, which keeps coming up in psychedelics. And in general, at our current place in Santa Monica, we offer holistic integrative psychiatry, psychotherapy, ketamine-assisted therapy, and we are braced and ready for MDMA and psilocybin. Oh, I should have done this before, sorry. We're ready for psilocybin and MDMA when we get the green light.
Great. Dr. Galbar, are you still on? I could do the question and answer Q&A.
Yeah, go ahead and do it. I'm still
Okay.
on. Go ahead.
Great. So we have, let's see, let me move up a little bit. Do any patients have bad trips or get worse after treatment?
Yes. Generally learned most of the lessons I've learned in life, I've learned the hard way. So ketamine and psychedelics are really good for trauma, even dissociative trauma, but we do have to be careful with clients. If clients are too fractured before coming in, they're not appropriate. There are a lot of people that are not appropriate for this level. And there are clients that show up and sometimes we don't see how disconnected their parts are, and they become destabilized. More often than not, I've seen clients, we offer psychedelic integration. So we get a lot of clients that come back from psychedelic trips in Costa Rica and other countries where they've become terribly destabilized. I've even had a bunch of calls where they're in Costa Rica, we get a call from the medic there, they're put on antipsychotics, they're sent back here, have a short inpatient stint, and then we work to stabilize. And it's a mixture of, if there's no previous psychotic breaks, then sometimes it's really the intensity of what came up too fast. Like we saw all of the release of information is too much too fast. And so it really takes a lot of time, sometimes up to a year, to get somebody back to stable if they've had a difficult break during a psychedelic experience. But it absolutely can happen. Yes.
Got it. Okay. Someone said, I've heard that MDMA and cannabis and possibly other drugs can activate potential for schizophrenia. How do you safeguard for that?
We screen carefully. So if clients have a potential for psychotic disorders, we don't offer them psychedelics. They've been any bipolar or psychotic symptoms were excluded from all of the research. So it's going to be kind of a learning experience for all of us if we legalize and utilize these when they're appropriate. And that's going to be a learning curve for all of us, because of course, no, we don't use it if there's true psychosis or schizophrenia. But as we all know, there's misdiagnoses and mislabels that happen and get labeled, and you get stuck with them over time. And so I really think it's just a matter of spending time with people and slowly teasing out what people are coming up with, and would this potentially be helpful? And also, that's where we get the psycholytic dosing options too. Should somebody maybe potentially benefit from this, we can go very low and stay with them. And a lot of it is about the relationship and creating a sense of safety and relational container with the clients.
Got it. Since you're talking about screening, what are you screening for?
I don't,
When screening?
I'm a harm reductionist, so I don't naturally screen out anything. I sit with people but I also don't screen in. Like, I don't think these medicines are right for everybody. I just think they are a tool like the other tools we have in our bag.
Right.
So it's hard for me to be specific about what I screen out for in terms to use these medicines, but I certainly wouldn't use it on somebody actively using unless they could stop for a couple of days. You know, as a harm reductionist, if somebody is in addiction and they have a lot of trauma and they've been stuck in this addictive path for decades, but they can be sober for a couple days, I'm open to having them come in a safe container. I never prescribe for at-home use, but to sort of develop a sense of open, undefended inquiry into why somebody continues a destructive pattern of behavior, I find really helpful. So I tend not to have substance abuse as a hard no ever. I would, however, have a hard no for decompensated people. You know, like if our clients are too activated and unstable, that's like a big red flag. Psychosis, it lends itself to instability, so that falls into there. Active bipolar 1, instability, anything unstable.
Yeah. And what enables the memories without emotional charge?
Say that again.
The question is, what enables the memories without emotional charge?
Oh, because we down-regulate blood flow to the amygdala, and the amygdala is that little nugget in our brain which is responsible for rage, anger, high emotions. So it's really fascinating. We've seen this on PET scans. We're reducing blood flow to areas of our brain that activate our sympathetic nervous system arousal so that we can be in a calmer state with these memories that come up. That's what happened a lot we saw that a lot in the MAPS training. Annie and Michael Mithofer actually they had filmed hours and hours and hours of working with vets. And there's one, Nick, he's amazing. He was in the experience, kind of reliving being in the Humvee and having the bombs go off and having his partners die next to him, he was able in this state to process the heartbreak and the trauma and having survived when they didn't, and all of the incredible difficulties he experienced. But they were things he couldn't even bring to his own service to talk about without being able to bring it down.
Okay. If you can comment on a time when the administration of ketamine or MDMA or any of these did not go well in your practice, and how did you handle it? Has that ever happened?
Yeah. So I'm not using MDMA because it's not legal, but ketamine for sure. So ketamine is generally, you go to psychedelic school and ketamine school and all these post-grad schools, and the recommendation is a certain amount per body weight. So I ask people how much they weigh and we get a sense, but also some clients come in and want to go really far out and they think they're ready and they definitely want this. So I've worked with clients and we were gentle at first, and then they came and they were like, no, I'm definitely ready. But I administered ketamine and the client was terrified the whole time. And there was nothing I could do aside from hold their hand and tell them, we did this intentionally together. We made a decision. We're 5 minutes in. It's going to last 40 minutes. We have 35 minutes left. Kind of talk them down the whole time. It was very stressful for them and me, and they never came back. So that was bad for my practice. And I felt terrible. There's a lot of things that you make mistakes along the way, you learn. And so I definitely I'm always super gentle. Another thing I learned from IFS, ask, like we ask with suicide, just because you tell me you're suicidal doesn't mean I'm going to hospitalize you. Like if you have any apprehensions about this, if there's any part of you that doesn't want to do this, it doesn't mean we're not going to do it. But let's bring them to the surface. Let's talk about them. Let's explore them. Because I've had clients that didn't share that because I didn't dig enough. And then they hold and they resist. And it's difficult for them, and it's difficult for me and or the other practitioners in the room, because we're not 2 feet in together. I'm sure I could talk much more about all the mistakes I've made along the way.
Got it. Are there any residential treatment centers that offer these modalities?
I think the Sanctuary in Sedona is pretty holistic. They don't even like prescribing meds, but they'll offer ketamine, because I think we couch this as a transformational healing modality, not an ongoing med that anybody takes, which is also a nice thing. It's like, let's get this so that you don't have to be on meds. That is kind of the goal behind some of the thinking. There are a couple more. I'm a member of a listserv with about 3,000 ketamine curious or actively ketamine using clinicians internationally. And so they're a really helpful resource. So should whoever asked that want a list, I could ask that question or search the archives of that listserv, and we'll get like a list of all of the places.
How much does the treatment cost out of pocket, and does insurance cover any of this?
Yeah, so the prices vary. Insurance, I offer a super bill, so insurance can cover. And with most insurance companies, they decide, you give them a CPT code and they cover it for a while, and then they decide they're no longer going to cover it for that CPT code. So then we have to get creative and come up with new ones, and we've done add-ons. That's also why it's helpful to be with this 3,000 group, because everybody's like, what are you using add-ons? What are you doing? But cost is a big barrier to care. And once these MDMA and psilocybin legalized, it's outrageously expensive. MAPS is even saying it's going to be like $50,000 for 4 treatments, which is let's say it was like 42 hours of treatment for one, so 40, 80, so like over 100 hours of clinical treatment at this price point. So group working with groups is a way forward to modify costs. And at Home LA, we've started a 501c3 so that we can offer this to clients that can't afford it. I personally don't exactly know how to get people to donate to the 501c3. I'm working on that. But we price it out. At Home LA, we're about $300 per clinical hour. So like a 3-hour experience is $900. And that's with oral, and it's $1,200 with IM. So it's super expensive. The coverage is usually about, I've seen 60%, 70 was the high end of coverage for the super bills. And it also depends on your insurance.
Right. That's right. Any psychotic breaks or other dangers and liabilities?
Yeah. I mean, psychotic breaks, we talked about that one for sure. Mm-hmm. Ketamine increases hypertension a little bit, increases blood pressure. So we do screen for hypertension. We screen for arrhythmias. We screen for glaucoma, because in some research, it increased the intraocular pressure in beagles, which,
oh, wow.
No, I know, it's so sad, right? I don't know how.
It's random, yeah.
So it's mostly cardiac. If you've recently had some stents or any cardiac surgery, you're not a candidate. Generally speaking, arrhythmias and cardiovascular is the biggest thing to look for in screening, not only ketamine, but also psilocybin and MDMA, because they also both increase heart rate. There's a PrEP. It's not Truvita. There's an HIV PrEP combo that decreases one of the enzymes that metabolizes MDMA, like quadrupling the dose experience.
Oh,
I can't remember what that one is. I learned that from one of the neuroscientists in psychedelic school, but I'm sure that'll be in big red letters on my wall once we're legal and we're allowed to use that one. So yeah, there are definitely more things that are going to come online to prepare for with psilocybin and MDMA. Not as much for ketamine. You know, ketamine's a generalized anesthetic. It came online in 1912 and it has been used as an anesthetic. It's so safe. That's why it's used primarily in the pediatric and veterinary population. So even when somebody has a medical compromise, if I call their cardiologist or their primary and the doc was like, you know what, I'd clear them for a procedure. So if what you're doing is a micro dose of what somebody actually needs to be put under for a procedure, so it's a reasonably safe from a medical transport perspective. It's just, what are we going to do with what comes up? And have we prepared for that? And have we created a container to deal with that?
right. Do you have any insight on navigating integrative psychotherapy without the medicine session stage? I know the green light is near, but in some states like Texas, it seems like we would need a plan for some intricate navigation of laws and protocols.
Will you do the first part, just the first part of the question again?
Yeah. Do you have any insight on navigating integrative psychotherapy without the medicine session stage?
Integrating psychotherapy without the medicine, like just prep, is that?
That's what it sounds like. And possibly maybe for states where they're not, where it might be difficult for these medicines to be legal. That's what I'm
Yeah, you know, even
getting from
now,
this
what we do
question.
here, yeah, like right now, we work with a lot of clients that are utilizing illegal MDMA, you know, people that are out in the world offering it, that there's got to be a nicer word than the underground, but there is an underground world of people offering both individual and group psilocybin and MDMA. So we do work with people without the medicine. It's about prep, you know, all of what's your intention. It's not really for the faint of heart, and it's not for people that aren't really prepared to see all the things that come up. So it's really important. That was kind of like in that set and setting. I don't think we can stress enough how important it is for a client to be in a solid relationship with a provider. You have to feel so safe so that you could talk about everything beforehand and then be open to continue. And also, it's not just talk therapy, because there's a lot of nonverbal or pre-verbal trauma. So we have some clients at home that have had stuff that comes up and then they like, now I can't, now my shoulder hurts, or like it gets caught in the body. So be willing to go to yoga, be willing to take walks in nature, be willing to get body work, be willing to be open to whatever healing modalities, and also be willing to do the work. Like, don't think it's the medicine that's going to come in and do something. It's about what you do with your time afterwards. Kind of use it. I almost like hope to be using it, not hope to, but like whether it's placebo or not. I tell people there is that critical learning window and that fertile period after medicine where engaging in behaviors that you want to engage in is really important to do, and to avoid the ones that you don't do. So if we're going to do a ketamine session, can you please make a plan the next day to go for a hike, go to yoga, don't bite your nails, forgive yourself if you binge, you know, for whatever happens, you know, just be aware that this is a period of time to be hyper aware that the thoughts that you're having can be laying down more foundational tracks.
Okay. Does the effects last, or do clients need more treatment later?
Oh, so it depends. Some of the motivation behind these, like I mentioned, is so that you get to the root cause of whatever your obstacle is and whatever you want to address. So if you do get to the root cause and you've worked with it, then you don't need continued sessions. But we're pretty complicated beings with a lot of layers. So generally speaking, that takes quite a bit of time. And if you're just using, you know, ketamine has a a molecular hat it wears, where like just the ketamine with nothing else is anti-inflammatory, antidepressant, increased cognitive flexibility. So people that use it like from the IV perspective and don't engage in therapy generally do a mess of sessions and then come back quarterly or come back monthly. And it's also helpful to augment therapy. If you have a monthly ketamine session, it makes you, in mice, the dendritic growth was seen to be strong. The second dendrite was stronger with more spines growing out of it. That lasts for about a month. So if you're in process, maybe do it monthly to sort of augment your capacity to make the most out of your therapeutic interactions in between.
Okay. Are there any things that clinicians commonly do wrong?
I'm sure. I mean, I've done so many things wrong. You know what I learned that was really nice also was that we're not the experts anymore. I think one thing that's really important for us to do is our own work. That's one thing I've sometimes seen some clinicians do wrong, is think, this was more in the underground, like think you're the answer, think you know more than you know, when we're all just learning this together. And to not interpret too much and to not put too much weight on what we think they should or shouldn't do. One thing that we do wrong is have intentions and have agendas. So we too have to kind of release that in this, and just stay open and stay doing our own work. I'm sure I could answer that better, but it's hard for me to think about what other people do wrong. I'm not great at, I'm more great at what I do wrong.
Okay, we're going to do a couple more. And your slides will probably be available too, right? We'll get them to Kathleen, right? Her slide set.
Do that.
Yeah, that'll be available on your console when you do the quiz for the CEUs, right?
I can't remember if that's part of it or if we've.
We'll make sure we get it to Kylie.
Yeah,
so everyone on this gets her slides.
So whoever's asking, definitely email me, which I put my email in the chat.
Okay. How addictive are these medicines?
Oh, that's interesting. There's a pretty low addiction profile for the traditional psychedelics. Ketamine and MDMA can be addictive because you keep feeling the high when you take it, and it's not necessarily that complicated. It's like relaxing and it feels good. So there is definitely an addiction and abuse potential for MDMA and ketamine. They're bad for microdosing. They're bad for at-home use. So I prescribe only for in-office monitored. They're very helpful. Like, it's like pain meds. You wouldn't say no to somebody post-surgery. If you need them, you need them. They're therapeutic and useful, but they are part of a package. They're not just the medicine. So that's kind of answers that other person's question.
Yeah, because you said you're in person.
Right? Yeah, and they're part of the like prep, medicine, integration, the whole thing is the treatment.
Okay. For clients with a history of misuse of hallucinogens, what would the therapeutic use of the same potentially trigger a return of problematic use?
I'll answer that. One quick thing also about ketamine. Another red flag is cystitis, because it's processed through the bladder. So anybody with a potential, that has like chronic cystitis is not really a candidate. And the abuse in clients sometimes results in cystitis. The potential benefit of psychedelics with somebody who has previously used psychedelics would be about positioning it differently. Like if somebody's actively using psychedelics, it's not an appropriate medication. But if somebody used psychedelics in their 20s and now they're 40 or 50 and they're coming up with these things, they're trying to process how to take care of aging parents, whatever. It's a mindful, intentional opening of consciousness. So it's not just psychedelic use. So if somebody is actually interested, even in spiritual growth, personal evolution, as long as it's very mindful and intentional, then I think there could be a debate for moving forward with it with most people.
Great. So we're out of time, but can you say what your website is again for people that are asking in the chat?
Oh, thanks. Did I?
Or if you want to put it up on the screen again. And thank you so much, Eva, for this. It was awesome. Really good information.
Yeah. So is that visible?
Yes.
Oh, there you go.
Awesome.
So that is and we'll have the slides available to you. Thank you so much, everybody, for coming. Happy Thanksgiving. Happy holidays. We'll see you in the new year.
Thank you.
Thanks,
Happy
Eva.
Thanksgiving.
Thank you.